Good afternoon, everybody. This is Dr. Kachikian from the Black Hills Regional Eye Institute, and today I am doing a case of ocular albinism. We're going to be doing the cataract and also placing an artificial iris within the capsular bag. If you can see this patient, the iris is somewhat translucent. You can see the red reflex kind of poking through the transillumination defects in the iris, and that is because this patient has albinism. They have an iris that is very thin and does not block light very well. And so the treatment, or one treatment that is available to these patients, is an artificial iris. And what that does is it blocks additional light. So their natural iris stays in place, but the use of the artificial iris blocks more light. It is not as transparent. It does not have as much translucency. So what we're going to do first is cataract surgery. We have made our sideboard incision. We injected viscoelastic to fill the anterior chamber, and we're going to make 2.4 millimeter keratome incision. And what you'll notice is, although this patient does have an excellent red reflex, I am going to stain the capsule with trypan blue. You can kind of see those transillumination defects there through the iris as well. But what we'll do is we'll stain the capsule with trypan blue, and there's two reasons for this. One, these patients can have some zonular laxity, so we do not want that to be an issue. And two, when we are placing the artificial iris within the capsular bag, it helps very much to be able to see the edge of the capsule, because you want to make sure that the iris is completely within the capsular bag. And so I was hopeful that staining would help later on in the procedure to visualize the edge of the capsule. So we'll get our anterior capsule stained, and then typically we'll use Utrata forceps to make our capsular excess. In general, I do place my trypan blue typically under a viscoelastic. I think I've used it in many ways, under an air bubble, without an air bubble at all, and just straight into the anterior chamber. And I think there's actually less endothelial toxicity when you place the trypan blue under viscoelastic. It works even better than an air bubble. So we'll use a little kind of outline on the surface of the cornea to create our capsular excess. We want it to be probably slightly larger than average, because we do want to be able to fit about 10 to 11 millimeter artificial iris, and we don't technically know how big it's going to be yet because we haven't measured for that. We'll measure it once the cataract is removed, but about a 10 to 11 millimeter artificial iris we want to be able to fit easily or fairly easily into the capsular bag. And so we want a reasonably large capsular excess, probably about 5.5 to less than 6 millimeters. You obviously don't want it bigger than the optic of the IOL, and we want to keep it as round as possible. So here we are creating a nice round capsular excess. It's going very smoothly, and again, although we don't need the staining to complete this, we will use the staining. Hopefully will be helpful somewhat later when we are placing the iris in the capsular bag. Now we will do our hydrodelineation and hydrodissection. It didn't appear as though there was really much zonular instability, but nevertheless we will be careful. Obviously, we want to have a good, secure location to place our iris. I usually will do hydrodelineation and hydrodissection. I do like to have the extra kind of protective layer of the epinucleus when I'm doing cataract surgery. So we'll make sure we get a good rotation, make sure we get a good hydrodelineation, and then reinflate with viscoelastic, a little viscodissection. I don't always do that. Then we'll start with our phaco. I usually will place the foot pedal in the quadrant removal mode to rid of any excess viscoelastic, and then typically do a stop and chop procedure, a few grooves centrally, and then use a second instrument to divide the nucleus in half, and then typically chop the nuclear pieces thereafter. This obviously isn't a very dense cataract, and so it will come out fairly easily. And typically we'll chop into quarters or sixths on a really dense cataract, maybe eighths. But as you can see, this is soft and it's coming out, even being able to be divided with the second instrument fairly easily. And we've got probably almost half the nucleus out at this point, and pretty soon we will work on removing our epinucleus. Sometimes the epinuclear layer is somewhat thick and it's hard to kind of get it to mobilize, but if you just keep rotating and grabbing the edge of the epinucleus, it will kind of eventually fold in on itself and you will be able to remove it. Leaving an epinuclear shell does take a little more time, but I do find that for me it works very well as a technique. There is the remainder of that epinucleus, and then once the epinucleus is completely removed, we'll grab our IA. Most of the time, if there are any pieces that are stuck to the endothelium or stuck up in the viscoelastic, I will leave those for the IA. I think it's a little bit traumatic to the eye and to the cornea to try and go after those pieces with a phaco handpiece. When we're doing IA, I do try and sweep kind of centripetally and pull the cortical material in a rotational fashion so that we're not pulling centrally directly. Usually I'll try and loosen the peripheral cortex and then sweep to remove larger pieces of cortical material. And as you can see here, that does work fairly well. Tend to get a very clean capsule bag that way. And then I often will kind of power wash the posterior capsule with some BSS to make sure any cortical strands have been removed. I also do kind of search for any nuclear fragments that may have gotten stuck either in the angle or between the iris and the anterior capsule. Now that we have got all of the cataract removed, we will inflate with the Provisc, and then I will always sweep using an anterior capsular polisher to remove any remaining anterior lens cells. And I'm not actually sure how much this helps. I think it does help. We reduce capsular phimosis a fair amount. I don't know that it helps reduce any PCO. You do want to be careful not to cause any additional iris trauma. One thing I noticed though is that it does look, makes the surgery in general look very neat. You do remove some excess debris, and post-operatively with Alcon lenses, at least, you do not get any peripheral capsular fibrosis, which can sometimes happen. It doesn't matter as much in this case because we're putting in the artificial iris, but nevertheless, I do it. Now we'll place a capsular tension ring here to help support the artificial iris, and it seems to me there's two types of capsular tension rings, whether you're going left or going right. It doesn't matter to me which one I get. I just flip over the injector if it's not working. I use a Sinskey hook to place the capsular tension ring, and the reason I do this is because I don't like putting direct pressure on the periphery of the capsule. I just like, see, there's now broad pressure on the periphery of the capsule, which is more tolerable to me than just kind of direct pushing. And then if you do it well, you can just release both ends almost simultaneously right into the periphery of the capsular bag. Now that we have got our capsular tension ring in, we'll reflate with viscoelastic, and we have to measure and we measure using an intraocular ruler. Here you can see the gradations. We're going to put it all the way in, and it gets to about, there's about 6. That's 6 right there. All the way to the edge is 6 millimeters. That's about a 12 millimeter angle to angle. Here we're going to try it again. maybe that's closer to 5.5. So 5.5 would be 11 across at a 5.5 millimeter radius. That's an 11 millimeter diameter, and we size down 0.5 millimeter. So we're going to use a 10.5 millimeter tree fine on our artificial iris, because we take the radius, multiply by 2, we're going to say that was 5.5. 6 was a little too far. 5.5 times 2 is 11, minus 1/2 is 10.5. So we'll use a 10.5 millimeter tree fine on our artificial iris. We have expanded the incision, and now we're going to place our IOL because that has to go in first. And the reason we had to increase the size of the incision is because the power of the lens is very strong. This is a high hyperope, and so the power of the lens was above 27 diopters, and so you need to use the larger injector. You need to use the B cartridge, and the B cartridge needs about a 2.7 to 3.0 millimeter incision, even though we're only mainly using a 2.4 millimeter incision to remove the cataract. So we will place our lens, and we want to get out all the viscoelastic behind the lens, because we're not going to have a chance to do that once the artificial iris is in place. And you can see our capsular axis is really very well sized. It's just under 6 millimeters, maybe even like 5.5 to 5.75, let's say. And so we'll get good coverage of the lens with the capsular axis, or I should say, I guess, bare coverage of the edge of the lens with the capsular axis. And we'll power wash one more time to make sure we get all the material out from behind the lens. And once the lens is in position, we can reinflate with some viscoelastic, and we'll move on to prepping our iris tissue. Get that last little strand of cortex out. We should be in good shape. Excellent. Now I'll put some Proboskin here, making sure to put some in between the capsule and the lens to create some space for the iris. We do have very nice capsular overlap of our capsular axis. And we'll make one more additional incision. And this is so that we can place some intraocular forceps and grab the opposite edge of the iris and pull it into place, which you'll see. Here's our fiber-free artificial iris. It's 12.8 millimeters. The reason it's fiber-free is because we're not suturing it. We're placing it in the capsular bag. The artificial irises with fiber are best suited if they need to be sutured into position. This is an iris for an ocular albinism patient, and so there's no color to it. It's black. They're all black, and it doesn't change the color of the eye to black. Remember, it just sits behind their thin, wispy, natural iris, and so the iris itself appears kind of, their natural iris appears blue, and this black iris that sits in the capsular bag will kind of enhance the blueness of their eye. It won't make their eye look significantly darker. Okay. Now what we're going to use here is a machine that's at the device that's made, I think, by Epsilon for centering the iris and the tree fine. And it's really, you know, kind of genius. It almost looks like a camera aperture. You place the artificial iris right over that center post there, and then you place your tree fine over the iris, and it doesn't have to be perfectly centered. And this aperture will center the tree fine for you. And this is extremely important because if the opening or the pupil of the artificial iris is not centered, then that's very obvious both to the patient and to observers looking at the patient that their pupil is really not as centered as it should be. And that can be, you know, frustrating. You're doing this very delicate procedure and you want the pupil to be centered. So you use this device, and it centers the ring for you. And you can just move it off center even a little bit and use the aperture, close the aperture, and the tree fine goes right to the center of the iris. Here you go. So that's just a very, very elegant device to do this. Now we'll push down on our tree fine to make our incision and remove the excess artificial iris tissue, because we decided we needed about a 10.5 millimeter diameter iris. And so here we have that. We'll tag and we'll see if we can just break that off. Yep, perfect. Now I will say that when you're cutting the artificial irises with fiber, they are much more difficult to cut. So keep that in mind. They don't cut as easily. Now what we're going to use is an ICL injector to inject this, and this actually works very well. Also, there's no injector for the artificial iris, so this is an ICL injector from Star, and it just works very, very well. You fold the artificial iris in threes, and it is kind of spongy, so it doesn't always stay that way, but by folding it in threes, it fits very well into the injector. So 1, and then 2, and then 3. So you fold the iris into thirds. Now it does want to open. It's pretty spongy. It wants to unroll. So once you have this, you want to kind of remove that one and be able to grasp it without allowing it to unfold. And you want to get the distal tip as narrow as possible, and then you can just kind of place it into the injector there. And it works very well. You push down and just slide, and it will slide right in. There we go. And then you will place this injector into the plunging mechanism, and then it will plunge the artificial iris forward very, very nicely. And then what we'll do is we will place this into our 3 millimeter incision, and we will work to get that iris under the distal edge of the capsular rhexis. Just like that. And if you inject slowly, kind of allow it to unfold almost like an ICL would unfold. And use your second instrument to kind of help it out. And there we go. Now we're pretty sure that it's under the distal edge. And you'll just sit like that, and there you go. It's popped in there. And this is where we will use the intraocular forceps. Once we get the majority of the iris unfolded and into the eye, not in the incision, then it's somewhat difficult to get the last edge of that iris under the proximal edge of the capsular rhexis. So we'll get in as much as we can, and then we'll take the intraocular forceps and use that incision that we made just at the very end of the last part of the procedure. We'll get as much of the iris as we can under the capsular rhexis till there's just kind of one wedge left, and then we'll grasp with the forceps from across the eye and get the last edge of the iris under the proximal capsular rhexis. And it just kind of goes very smoothly. We'll grasp. A little hard to see, but you can see the edge, and you just grasp it, and then just pull, and you can see the edge of the capsular rhexis, and there it goes. So that's a good visualization of the edge of the capsular rhexis and the iris going under there. And then if you want to confirm, and it is a little hard to confirm, and I'm not sure that in the video we'll be able to see it, but I take the Sinskey hook and zoom in, and you can just see the edge of the Sinskey hook tenting up the edge of the capsular rhexis. And I could just barely see it in the microscope, and it's harder to see in the video, but you get the Sinskey tenting up the edge of the capsular rhexis, and you can be certain that the artificial iris is under the capsular rhexis for about 360 degrees. You can kind of gently position it, and you can see that the artificial iris is fairly well centered in the visual axis, and the centration is really excellent. And to be extra certain, you can use some Myacal and bring the pupil down, or some Myostat, but sometimes it doesn't always bring the pupil down as quickly or as nicely as you'd like. But so in this case, using that tree find and the tree find centration device really allows for the pupil to be centered. Now we will remove all of our excess viscoelastic with the IA. Remember, all the viscoelastic behind the lens has already been removed. In these patients, I don't hesitate to give them a warm Diamox postoperatively to ensure they don't have any intraocular or postoperative pressure spikes, rather. And then once all the viscoelastic is removed, we can work on sealing our incisions. Now this patient has, obviously, his albinism is a bilateral condition. And so I can't actually remember if this is his first eye or his second eye, but we did place these artificial irises in both eyes. He also has some nystagmus. And so this was done with a block. Because of the nystagmus, it's hard to control. And I think his baseline vision is somewhat reduced from his albinism and nystagmus. But the subjective results of light sensitivity and visual function were basically off the charts. Really excellent outcome. We've already placed the myocol, but it didn't too much to the pupil. It may have been myostat. And that concludes our case. I do have another video suturing an artificial iris in a patient without any capsular support, so check that out if you are interested. Thanks very much for watching. This is Dr. Kachikian with Black Hills Regional Eye Institute. I hope you folks have a great day. Bye now.